طالعه من البيبيلاري اريا وزق الايرس عاملالي narrowing of the angle. عندي another cause الاي او ال implantation لما بتبقى فيها مشكله، فدي كانت pupillary block pupillary capture IOL زق الايرس وابتدت تعمل لي peripheral anterior synechiae، وعلى حسب الكوادرنتس اللي عامله فيها بيبتدي يظهر عندي increase في التنشن. ده longitudinal view مبين لي البريفرال انتيريور synechiae بتاع الاي او ال. التروما كمان ليها نصيب في انها تعمل لي جلوكوما، يا اما بوجود حاجه زي هايفيما والبلاد سيلز اللي بتقفل لي الانجل، او ان البلاد سيلز دي تبتدي تعمل ادهيجن، تعمل ايريدوكونيال ادهيجن وبريفرال انتيريور سينيكيا خلال الانجل، او في حاله زي الانجل ريسيشن where there is a tear in the ciliary body with the remnant of the ciliary body still inserted in the scleral spur. على قد الانجل ريسيشن ده واخد قد ايه في الاي 1 كوادرنت هاف كوادرنت، الكلام ده كله بيحدد لي افكتنج البريشر ازاي. واخيرا طبعا اللوفياتيك بيشن الانفلاميشن بتقفل لي الانجل، الاوكلوزي بيبيلي عامله ايرس بومبي وتوتال ايريدوكونيال ادهيجن فعامله الانجل في الكورس تقريبا كلها. الكونكلوجن بتاعي انه اليو بي ام بيبقى سهل انه يفرق لي ما بين انواع الكلوجر او الاوبن من الكلوجر، ويقدر يفرق لي ما بين انواع الكلوجر انجل جلوكوما. كمان بيقدر يأسس كل الحاجات اللي بوستير تو ذا ايرس بسهوله، سالكس سيليري بوديز اون يوز لينس الكلام ده كله، وده بيبقى طبعا a good guide for surgical intervention. Thank you very much.
شكرا دكتور Now, Professor Sagan Sanadari will talk about how to evaluate progression in glaucoma. Professor Sagan.
We come to the end of the session, and at the end of the session we'll talk about the evaluation of progression in glaucoma. And as we all know that always we diagnose glaucoma by the optic disc, the field of vision, the OCT for retinal nerve fiber layer, the OCTA, and also these factors will be used for evaluation of progression. For example, for the optic disc, as we see, when we see a flame-shaped hemorrhage like this means that this patient is not controlled well and he needs better control. For the field of vision, which we always depend on, but sometimes we have only two fields. How to evaluate progression when we have only two fields? We search for a deepening scotoma, which means progressive decrease in sensitivity in a localized area, like we see here. Or we'll search for a new scotoma, a new significant scotoma in an area which we consider one of the areas sensitive for glaucoma, like we see here. But if I have more than 3 tests, I can use the glaucoma progression analysis. And the advantage of glaucoma progression analysis that I have what we call a trend analysis, as we see, plotting the mean deviation along the different tests and showing if the mean deviation is progressively low or is improving. And then I will analyze an event analysis, which is the appearance of new scotomas for the first time, for example, marked by this empty triangle, or for a second time marked by a divided triangle, or for the third time marked by a black triangle. Also in octopus we have the same, almost the same. We have a mean defect progression slope, and it will indicate the rate of progression per year and its significance. Also we have marks like the rectangle, the yellow diamond, identifying areas of progression or fluctuation. In the case of advanced glaucoma like this, and this is the main question, How can I do test for progression with this field? We usually resort to 10-2 in order to magnify the central area, which is usually the tubular field. And we may have this presentation giving hope for the patient that there is improvement. But sometimes, even with the 10-2, I can't do follow-up because I have a marked affection of the field. I can go to the automated kinetic perimeter. And as you see, when I see the field, I can estimate any area that can improve. But with the automated kinetic perimetry, I have a wider isopter and I can follow with this isopter. And in this case also, in spite of doing the field with a large target like 5, and the 10-2 also with a large target 5, but in the automated kinetic perimetry, I have a larger isopter that I can use it for follow-up. So the recommendations when I do follow-up for the field, it's recommended to use the standard automated perimetry, except if I need to use other tests like the kinetic perimetry. Recommended to use the zeta fast. The zeta fast is preferably for screening. It's usually we use zeta standard more than full threshold, as shown by my colleague before, because the full threshold is very tiring for the patient. The new tests like the SWAB or the FDT or the PULSAR are new technology, usually used for early detection, but for follow-up. And of course, we have the third exam. What about the OCG? The OCG, as we all heard, that it is structure. And the advantage, like the field, it has a normative data, it points out the outside normal limits and the within normal limits, but I should always look for the quality of the image. And I shouldn't accept a poor quality, whether I am the operator or I am the glaucoma specialist. And these are the parameters for the signal strength index for the different instruments, and I should have an eye tracker. This is an example how to evaluate progression with OptoView. I have also took always the event analysis and the trend analysis. The event analysis will show progression in a sector. As you see the arrows here, in this sector it was 94, then it became 82, then it became 77. And the trend analysis will show a comparison, a curve, a linear regression curve for the average retinal nerve fiber layer, the superior average and the inferior average, and it will have the maps for the thickness, for the deviation maps, and the significance. Significance maps will show the event analysis. This red area means that I have a trend analysis. I have the curves. Also in serous glaucoma progression analysis, we have the same. We have curves for the average retinal nerve fiber layer, the superior and the inferior thickness. So for the follow-up in OCG, we shouldn't depend only on the event analysis. It's better always to use also the trend analysis, although it is lengthy in time, because the rate of progression is important. However, when I have an advanced glaucomatous OCG changes like this, the floor effect, the OCG has no value in progression. Now, I can't use OCG to evaluate progression. Please, if you have this, don't follow up the patient with OCG. It has no value with this advanced ganglion cell atrophy. So what I do, maybe we have the hope with OCG angio. As Shima have demonstrated, that OCG angio will measure vessel density. I have no normative data, but I can follow if the vascular density will diminish on different exams. So this may be used as a progressor indicator. So if I have progressive changes despite monitoring education, how can I manage? How can I think? As Professor Sanjay have said, we should exclude if I have a brain lesion, compressive, vascular lesion, anything that developed with the patient and lead to the change of his field, like we see in the field here, we have a homonymous anopia. We should measure the IUP at different times for the spikes. We should look for the fundus if we have cataract for age-related or ischemic optic neuropathy that damage the field more. And we should look for nocturnal hypotension because nocturnal hypotension, if the patient is on antihypertensive treatment, can worsen also the glaucoma. And then we'll come to think what we do, whether it is medical, surgical, or legal. Thank you.
Any question? The floor? Thank you. Okay. Closing the session.
So we continue for the second session or EEG meeting. And in this session, actually, I take the chance to introduce our two guest speakers. The society is blessed this year to have two true glaucoma scientists, surgeons, and eminent speakers in all worldwide glaucoma meetings. Actually, we are blessed to have. Both are actually very dear friends. I have the next slide, please. Yes. So Professor Tina Wang of Singapore. Actually, this is not her first time in our meeting. I don't know if she knows that or no, but she also was a guest speaker in our 2020 meeting, just after the COVID. And I claim that we were the first ophthalmology meeting in the world after the COVID crisis. It was in October 2020, and I was putting the meeting on international sites, and there was nothing but actually the Egyptian Glaucoma Society, and a few weeks later other meetings came, and it was a hybrid meeting, and it was, I remember we were sitting in a hall, and the whole attendees, we took a picture at the end, and we were 30 something, but we had 200 plus online international attendees from several countries of the world, and Professor Tina was among our dear speakers and kept the discussion in this hybrid meeting. Professor Wong is a senior consultant of the Glaucoma Service at the Singapore National Center. She is the current vice president and faculty and professional development for ophthalmology at National University of Singapore, director of the Clinical Translational Research and co-head of the Ocular and Drug Delivery Group at the Singapore Eye Research Center, special interest in ocular scarring and post-glaucoma surgery management. She leads an interdisciplinary research program on translational and clinical research on developing new therapeutics as well as drug repurposing and sustained drug delivery systems aimed at improving patient adherence and surgical outcomes. These are all difficult terms, but we are going to try to follow these. So, slide please. And dear friend, Professor Sanjay Asrani of Duke University of the United States. He is Professor of Ophthalmology at Duke University, Director of the Duke Eye Center for Carie and the Duke Glaucoma OCT Reading Center. He is a recipient actually of numerous awards, including the Career Development Award from the Research to Prevent Blindness, the Helen Keller Award from the American Glaucoma Society, the Senior Achievements and the Secretariat Awards from the American Academy of Ophthalmology. He has, as we all know, over 100 peer-reviewed publications. He serves on the editorial board of Ocular Glaucoma, the Advances in Therapy and Ophthalmology and Therapeutics. He has developed a new glaucoma implant and a new software for OCT for glaucoma diagnostics, and I'm sure we are all going to enjoy their talks, learn from their talks, because they have varying talks, and actually they have sent few suggested talks, but me and myself and the board, we decided to capture all the talks they send it, so we are consuming their efforts, but we are very happy and glad to have these two figures in our meeting this year. So we are honored, of course, to have Professor Tara Al-Nasra as a co-chair with Dr. Hamid Al-Ouf.
We'll start the session with the Dr. Ahmed Benanget, and he will talk about trying to understand AI.
Assalamu alaikum, good morning. I'd like to express my thanks to the special thanks to my professor Al-Abez. And I'd like to start my talk. We now are always talking about AI, and the field of glaucoma is full of the application of AI. And now we want to talk about how to learn the AI in general and especially in glaucoma. So first of all, what is the artificial intelligence, or what is the AI? It is a field of computer science that creates systems which can simulate human cognitive functions like learning, problem solving, and decision making. So to understand more what are the types of artificial intelligence, we can look at this figure. It can summarize the types, or we call it the stages of development of the artificial intelligence. The artificial intelligence is the broad term. Under it, we can find a much more precise term like the machine learning, and more advanced. And the more advanced form of the AI is the deep learning. To start with the artificial intelligence in general, to know about it, first type is the symbolic or the rule-based AI. The example of the symbolic or rule-based AI, one of the most famous is the calculators. All we use these calculators. Also, another example is the chess playing computer. And to know how this chess playing computer was developed, you know that there is a program called the Deep Blue program, which was developed by IBM to compete with Garry Kasparov, the worldwide champion of chess. And this system has taken about 12 to 14 years of development until it reached the full form. And this is very time consuming. And this have pushed the scientists to develop what was called machine learning. By developing this machine learning, you can just give a criteria for the computer. You can tell him, if you can find this criteria, this is a triangle, and if you can find those criteria, this is a triangle, and if you can find these criteria, this is a rectangle. And by knowing that, the computer itself can do clustering of these figures. And if you can give the computer a randomly arranged shapes, it can collect and it can arrange them into clusters or groups. Or he can do regression analysis for the change of the shape of each pattern. And the good examples of the machine learning in our life is the email spam filter. It can collect spam emails from our emails to a single folder. Or the taxi application like Uber, the Facebook application like face recognition, and in our life, in many ophthalmic machines like we have heard today, in the OCT and visual field, as we will see. This also have pushed the scientists more to develop what was called the deep learning. To understand what is the deep learning, we should know about the artificial neural networks. What are the artificial neural networks? This photo shows us the human neuron. And this human neuron can take the inputs through the dendrites and have processing of this information inside the cell body and transfer this information to the output as the terminal nodes. These figures has inspired scientists to develop a mathematical model. This mathematical model you can see here on the right side, this mathematical model showing us the input can enter through multiple ways to be processed in a mathematical formula to get the output. This output, I can look for this output. If this output seems arranged with what I need and is coincides with the results we need, it's okay. And if it's not coincide with this result, there is a feedback for changing the input to reach the desired output. This is called the artificial neural network, and you can see here on the right side is the output numbers. If these numbers is not coincide with what we need, we can go to change what is called the weight. This weight is, as you can see here, these weights are number multiplied by these inputs. And by changing these weights, we can go for the desired output. This stage of making the neural network is called the training of the network. At this stage, all the programmers can give the computer the inputs, and all the programmers can give the computer the input and train the network to see the output. After finishing the stage of training, the network is now ready for population to use. If you look to this model, this is a single neuron, and this is a single artificial neuron. If you have taken this single artificial neuron to enter into a deeper network with input layers and multiple hidden layers, you have output layers. This is called the deep neural networks. This is the core of the artificial intelligence, and this is the core of the deep learning. In machine learning, if we compare it to the deep learning, the difference is in machine learning, you give the computer the input, you give him the criteria to extract the feature, and the computer will do the classification and give you the output. On the other hand, in the deep learning, you just give the input and the computer itself can go for feature extraction and do classification and get you the output. So by comparing these models is very, very time saving in deep learning. So these are the first image of artificial intelligence, which includes the machine learning and then includes the deep learning. So what are the applications of what we have said in our life as glaucoma specialists? First of all, as all my professors before said, the field of vision or the perimetry, we have the machine learning which can recognize the visual field effects. We can do no output laser steps. We can do automated visual field classification, either glaucoma or non-glaucoma. Also, we can predict future field progression. In the optical coherent tomography, also we can use the machine learning and we can use the deep learning models. We can detect structural damage earlier than traditional metrics. Also, we can analyze retinal nerve fiber layers and ganglion cell complex, which can predict further visual field loss on the baseline OCT. Also, by integrating monitoring intraocular pressure, like using the new things like smart contact lens with the AI algorithm, can analyze continuously the fluctuations into intraocular pressure, and it can predict the model which patient need closer follow-up than the other one. Also, in screening, by using the optic disc or fundus photographies, systems like iPredict and Pegasus, they are project-based for AI screening in primary health care. Also, they are using convolutional neural networks trained on thousands of labeled fundus images. In the post-operative, we can use the AI and OCT, anterior segment OCT or slit lamp photographies of lip, and by using the deep learning models, which can objectively grade lips, vascularity high and wall thickness, which can detect early signs of fibrosis or impending lip failures. Also, by integrating the AI in peri-ophthalmology, we can use the home IOP monitoring with remote optic nerve imaging, which allows automated remote follow-up with automated alerts for progression. Also, in the field of training on surgical maneuvers, the AI and VR simulation can be integrated to practice FICO and MIGS procedures with real-time scoring, feedback, and analytics. And lastly, the robotics can be used in near future. There will be two robotic systems which allow remote surgery training, which enable collaboration surgery between experts and training. Thank you.
Thank you very much, Ahmed. And now, may I call Professor Tina on to talk about new ideas for glaucoma management, sustained drug delivery, and beyond.
Thank you very much, Ahmed, for a very nice invitation. It's always nice to come back to Egypt. In fact, my husband's gone for hunting 4 hours out of Cairo now. So I'm going to talk about new ideas for glaucoma management. This is an area of my research interest. These are my financial disclosures. So glaucoma right now is dominating, it's a major cause of irreversible blindness in the world. So we're number one, but it's not a really good number one spot to have, but here we go anyway. And you can see from the treatment pyramid here, glaucoma management, we have many options. And the options start at the beginning, which is first line treatment is always eye drops, and then relate all the way up to surgical interventions. However, what I want you to know is that eye drops is the foundation of our management, and it ranges from the mild all the way up to severe glaucomas. It is still an important tool for us. For surgical options, glaucoma, I tell my patients, is a good time to have glaucoma because we have many things in the bag for surgical treatment. However, what happens when the surgeries fail? We always fall back to medical therapy, and it always seems to be the go-to adjunct when our surgical options do fail. But as we know, limitations of eye drops There are many. I'm not going to talk about it in my talk. I believe Dr. Kamal, after me, is going to speak about this. Topical medications are good. They are effective only when they are used at the correct timing and when there's appropriate installation techniques. We can't control that, but perhaps what we can do is to take the patient out of the medical equation and maybe replace the way we deliver medicines into the eye. And so new treatment regimes have sought to introduce novel drug delivery systems to effectively lower intraocular pressure by bypassing these challenges and the patient, him or herself. Are we ready, though, for drug delivery systems? I believe so. We actually conducted a survey and just over 150 of our patients at the National Eye Center. And we asked them, would you trade your eye drops for a sustained delivery system that will keep your pressure low for 3 months? And about 3/4 of them agreed to this. Those individuals, no surprise, were on more bottled medications, medicating more frequently, and admitted to non-adherence. And since then, for the past 20 to 25 years, there's been a lot of investment and interest in drug delivery development. But only 2 of them have reached our markets. And I'll just quickly go through what they are. The first one is Durysta, which is owned by Allergan. It's an intraocular implant of Bimaticos, which was approved about 15 years ago. In their pivotal trials, they had declared that there was at least almost 30% reduction in IOP that could last up to 2 years. The indications are only for open angle, and of note, it is not approved for angle closure eyes. There was a reported endothelial cell loss of about 5% at about 20 to 24 months. There is a risk of a movement of the intracameral implant in the anterior chamber angle, and therefore you can also have some induction of intraocular inflammation, at least at the early stages of the implant. And it is contraindicated to be used repeatedly in the same eye. The second eye dose, which is by glaucoma, this is a tripos intraocular implant, and it was approved a few years ago. This implant is similar application to their MIGS, which is the eye stent. It's a surgical procedure. You have to take the patient into the operating theater. Again, it is only approved for open angle eyes, not approved for angle closure, and this one particularly because of scleral anchoring problems of the device. Again, they can stimulate some iritis, at least in the initial early few weeks of implantation. Again, it's not approved for repeat use. However, this device has not shown any endothelial cell loss, at least for 12 months or more. So why aren't these more widely used, you would say? Well, first of all, let's just look at the numbers. There's a cost-benefit analysis here. We're talking a lot of money. Okay, if you look at it, one single Durysta or the eye dose compared to a bottle of Zalatan or Timolol, you're talking about a 2-year supply of latanoprost is still 4 times cheaper than a single Durysta and 30 times cheaper than a single eye dose implant. Moreover, one-time use is not very attractive to our patients who have chronic glaucoma. There probably are better alternatives like MIGS and SLT out there. Glaucos is trying to address this by having a refillable device. Will it work? Will it be adopted? We don't know yet. And the final thing is that it's excluding angle closure. We know that angle closure is prevalent. About 50% of the patients around the world have angle closure. They're not benefiting from drug delivery either. So we're missing a market there. We need to know about drug delivery systems in the real world. And what am I talking about? I'm talking about considerations of quality of life, cost-benefit analysis, and reimbursement models, which are obviously very challenging for our current climate, and it is also very country-specific. So let me think about, okay, what about if we do a liquid injectable? It might be cheap, and it can be done in the office. Would that be an option for us? Well, I've been working on this for the past 15 years on a nanomedicine to load latanoprost and inject it as a subconjunctival procedure in the clinic. You can look here that, using nanomedicine is the beauty of it is that you can load a tremendous amount of drug in the same volume as a single eye drop of latanoprost. And what we showed in our pivotal study, our first in human, was that we were able to achieve at least 30% reduction in IOP from a single injection. And some patients continue to enjoy low pressures up to 3 to 4 months after exiting, which means about 6 to 7 months of IOP lowering. So I would say that the remaining unmet needs in glaucoma management can be filled by sustained drug deliveries. We're looking for long-acting and compliance-enhancing solutions. We're looking for innovative, differentiated options that we have currently. And it has to be complementary to existing management options. And if we look at this US survey, which is based on physicians as well as patients, we seem to be now ready for an injectable solution. So what is on the horizon, you may ask? Well, the suprachoroidal space is a space that is, we are aware of, but we don't really venture into it as glaucoma specialists. Our retinal folks are already using it to deliver their anti-VEGFs and triamcinolone. But what I would say is that perhaps for us, we're more familiar with this space for devices such as the CyPass in the past, but also the mini-jet. However, no drug delivery systems are using this space for glaucoma until now. And I'd like to just reveal to you that I am actually looking in this space as a new opportunity to deliver sustained release IOP lowering solutions. Here you can see an HME where you can see that when we inject into the suprachoroidal space in a cadaver rabbit eye with trypan blue, you see in the blue arrows that the trypan blue starts to diffuse into the sclera, meaning that if you inject into the suprachoroidal space, you can actually have a depot in the sclera to allow the drug to be eluted over a long period of time. And that's exactly what we want to show. IOP lowering, post-suprachoroidal injection of the same formulation that we tested in our patients. In a rabbit, we were able to see IOP lowering for up to 90 days. And so this is something that we are continuing to explore. Finally, drug delivery. Beyond drug delivery, let's talk about genes and nucleic acids and all these fancy things like anti-VEGFs. Well, what can we do in glaucoma? There's been research that's now targeting key pathways that are involved in aqueous humor homeostasis, like the MMPs, modifying the trabecular meshwork, aquaporins, movement of aqueous from one chamber to another, and of course, neuroprotection. sRNA, mRNA, and CRISPR gene tools will aim to provide a more durable long-term solution for managing glaucoma, but we still need to know how to deliver it. Now, we know that adeno-associated virus platforms are the main method for loading genetic material, especially for inherited retinal disorders, but they come with risks of autoimmune reactions which are very off-putting. So non-viral delivery platforms are being explored as safe alternatives. So I would say that sustained drug delivery will complement all forms of glaucoma management. And in conclusion, I think sustained delivery is the final missing piece in glaucoma management toolbox. Patients are receptive to alternative methods other than eye drops to receive their glaucoma medications. And I think all of us here and other glaucoma specialists around the world are comfortable embracing new technologies. I would like to invite you all, I've been invited here, but I'd like to invite you all to come to Singapore next year for our exciting program for the Asia Pacific Glaucoma Congress. It is also SNEC's 35th anniversary international meeting. So I hope to see some of you or all of you here, and thank you very much for your attention.
Thank you, dear Professor, for your lovely presentation. And Dr. Kemal Rafik, it's my pleasure to hear your lecture about eye drops. Are they going to extinct or not?
Thanks for the board for inviting me today. The topic here today is eye drops, are they going to extinct? I have no conflict of interest. Of course, eye drops are still the gold standard initial treatment for most angle glaucomas or for forgetfulness. But from forgetfulness through obtaining eye drops comes like availability and financial issues to run installation of house Non-adherence and non-persistence were major drawbacks of eye drops use. And sometimes I feel like it's more dangerous to give the patient eye drops than not giving him treatment. So the rise of new patient-dependent, independent ways are more than needed to bypass those in schedule adherence and resistance issues. The alternative will be one, or mostly will be one of three major categories, like sustained drug delivery systems, as Tina wonderfully explained, or lasers or surgeries. This is a reminder of how can we, how can we deliver the drug to the eye without using the scheduled patient-dependent eye drops. Extraocular ways, conjunctival forceps, inserts, punctal plugs, nanoparticles, lenses, periocular repose, microneedle array, and intraocular ways like intracameral implants, intraocular lens implants, and suprachoroidal. Now we come to laser as the first line of treatment. Of course, SLT, or selective laser trabecular plasty, through the famous light study, or laser in glaucoma and hypertension trial, compared the eye drops versus SLT in ocular hypertension and mild to moderate, mainly primary open angle. About 74% of patients at 3 years and about 70% of patients at 6 years were eye drops free. And of course, the rising other lasers like MLT, which stands for micro laser trabecular micropulse laser trabecular plasty, or flight femtosecond laser image guided hypercision trabeculotomy are showing very good results. Surgeries as alternative or first line. Of course, we all know the classic indications for glaucoma surgeries: failure of medical treatment to achieve target IOP, glaucoma progression despite well-controlled IOP, inability to use medications, as we said before. But the last few decades, new indications are unlocked as newer weapons are available. It's well established now that we offer surgeries as the first line of treatment in severe glaucoma at presentation. But based on their high safety profile, since the introduction of MIPS, a growing and powerful change of concepts that defies the classic concepts of using eye drops as the first line of treatment in milder forms of glaucoma. Now we offer MIPS unconditionally in all stages of glaucoma in combination of cataract surgery as a replacement of eye drops. Even more, and interestingly, many authors had the courage to test primary surgery in medication-naive patients instead of using a major blinding disease, and they can prove every day that you are more reliable and safer or against it. Thank you.
Thank you for the very precise presentation of this is. So we come ahead. We guidelines for 2020 PhD guidelines.
Everyone, it's an honor to be here. I will briefly review with you some highlights from the most recent EGS guidelines. So EGS stands for the European Glaucoma Society, which had its very first meeting in 1978 in Belgium. Only 2 decades later, the first edition of this terminology and guidelines for glaucoma was released, and it essentially aimed to complement the existing literature and serve as an aid with dealing with glaucoma in an evolving environment. This is 1997. Later on, more things were published, second, third, fourth, fifth, sixth edition on 2025. So before proceeding further, just to tell you that I'm just a messenger here, so I'm disabled. But take care that patients with high IOPs, severe disease might need more intense treatment or combination of treatments. Prostaglandin represents the most effective medication to treat glaucoma. There's primary open-angle or occlusion glaucoma. There's no difference between preservative and non-preservative free medications, but preservative-free medications are more access-friendly and hence more tolerable, but they are more costly. What about surgery? Surgery for advanced open-angle glaucoma. So surgery should be considered when medical treatment or laser is unlikely to maintain sight, and reflective represent the most effective treatment in terms of IOP lowering. However, stand-down mix, although they are on the rise, they mainly aim to reduce the IOP or the medication burden in early to moderate glaucoma. Other reforming surgeries can represent a potential versus classic mix. But for advanced glaucoma, trabeculectomy still is the most effective line, and it can be offered as a primary intervention because it has been shown that trabeculectomy can lead to better IOP and visual field fluctuation versus medical therapy. But for advanced glaucoma, there are reforming and other medical-related reforming surgeries that can be used. What if glaucoma and visual significant cataract coexist? Well, the decision here will depend on whether the IOP is controlled or not. If the IOP is near target, then phaco or phaco mix can be performed. But if the IOP is significantly off target, then glaucoma intervention should be carried out whether phaco or without phaco. Please note that cataract surgery alone is not recommended to control glaucoma, despite its modest efficacy in reducing IOP and medications. And since we know that reforming procedures work best when performed alone and not combined with cataract surgery, performing cataract surgery first is advisable if the clinical condition allows. So what if the glaucoma is more advanced? Well, interestingly here, the guidelines make a difference in how we should approach these patients. It still will depend on whether the IOP is at target or not. So if the IOP is at target, phaco alone or phaco mix. If above target, glaucoma surgery primarily. Note here that the guidelines didn't make a much difference in management whether the glaucoma is advanced or early to moderate, but whether the IOP is at target or not made a difference. What about alternative treatments? So there is no evidence regarding acupuncture and acupuncture and these medications in glaucoma management. There is no enough evidence regarding neuroprotective agents. However, there are ongoing trials regarding nicotinamide only as a potential adjunctive therapy for glaucoma management and not as a primary treatment. How about frequency of testing and monitoring? Well, there is no evidence regarding which combination of tests at this frequency is best to improve the patient outcomes at a sustainable cost. But a follow-up interval of less than 1 year for just ocular hypertension is unlikely to be cost-effective. With regard to frequency of testing and monitoring, these are factors to consider: glaucoma severity, whether the patient is fast aggressive or not, whether the target IOP is achieved. Are there other risk factors? And we might need a second test just to establish this finding, or if we think there are others. Most clinicians will consider that to detect progression, we need at least 5 tests, 2 baseline and 3 follow-ups, and to detect or to obtain a representable numerical progression value, we need at least 2 years. However, some clinicians might think that performing 2 to 3 tests per year could be enough to detect past progressors. Second part of my talk will be some points that you need to choose wisely or to avoid. Do not use research results driven from samples that do not represent your patient. And we will come at that later. Do not perform LPI routinely in back size. So you can perform LPI with text class size as defined by the neurological ophthalmologist, which include only eye patients, those with hemiastrial anti-closure disease, hyperopia, the need for frequent pupil dilation, the usage of anti-cholinergic medications for patients who are remote or vulnerable. Similarly, do not perform clearance inspections in patients aged 50 years with anti-closure who are at low risk of vision loss. And we refer to the EAGLE trial here, and we emphasize that the inclusion criteria for the landmark EAGLE trial were picked patients who are at least 50 years old, had primary angle closure with IOP at least of 30 millimeters of mercury, or primary angle closure glaucoma. Not use AAC angle imaging methods as a placement for endoscopy. These techniques are largely uncertain and they can miss valuable information such as pigmentations or perfective saniki. Do not use corrected IOP ready-to-use tables such as this one. These are not validated and should be avoided. Do not focus on come to this creation on optimistic assessment, actually to observe its appearance, size, shape, and the thickness and color of the rim, and the infilter could be here. Do not diagnose glaucoma based on OCT only. OCT is just a statistical deviation from reference database, and do not make decisions based on AI. AI is just here to support you, but not to replace your clinical judgment. Do not offer genotyping for patients with primary open glaucoma. Actually, this is a luxury, and we don't do that here. But who can benefit from genotyping? Patients who come from families with known multiple types of glaucoma start at a relatively young age. They should be offered genetic testing for mild mutation. Do not try neuroprotective agents as a replacement for IOP lowering therapy. Treatment should be prioritized regarding IOP lowering medications. And do not presume or assume that acute angle closure is always due to papillary block, because the ministry of management pilocarpine can worsen angle closure that's due to lenticular or retrolenticular mechanism. Do not forget to measure the excellence in patients with angle closure with shorter eyes at a particularly high risk of surgical complication. Do not perform further intervention on type unless there is pain and the pain is due to high IOP and not due to something else. Do not consider MIGS as a procedure without considering the risks or the costs. And finally, do not use MIGS on rapidly worsening patients. MIGS in general are best suited for patients who have mild to moderate disease, has bad ocular surface, or compliance or bad tolerance. For more information, please refer to the published guidelines, and thank you for your attention.
Thank you, Dr. Mohammed, for your last lecture. Now, it's my pleasure to hear why. Welcome, Professor.
Thank you once again. Ahmed asked me to provide a list of topics that I would like to speak on today and tomorrow, and I gave him 5, and he said all 5. So you're going to have to listen to me a total of 5 times today. So let's talk about home tonometry. The pressure fluctuations. So intraocular pressure is measured by us 3 to 4 times a year. The total pressure data is 6 out of 31 million seconds in a year. Little is known about the pressure fluctuations because we don't have a way of checking the pressure in the patient's own environment. Imagine checking or managing diabetes in today's day with going to the laboratory and checking your blood sugar 3 times a year. That's what we are doing in glaucoma right now. Patients are coming to our clinic, getting it checked 3 times a year, and we are assuming that their eye pressure is the same from one visit to the other. And we know that that's not the case. We also know that the sugar also is not the case. It is not stable, but we don't have a hemoglobin A1C like the diabetic doctors do. 3 types of pressure fluctuations. One is the ultra short-term fluctuations that occur in minutes. These are like when you hold your breath or you rub your eye. Those ultra short-term fluctuations don't really make a difference to glaucoma. And for example, patients with blepharospasm, patients who got keratoconus, who rub their eye all the time, they don't develop glaucoma. So those ultra short term are shown to be also in the laboratory, not to be important. But short term and long term ones are critical in management of glaucoma. And there is a summary paper on IOP and fluctuations over the last 35 years. Information in this paper that is open access in progress in retina and eye research. This is the study that showed that the fluctuations that are ultra short term, lasting for about 15 minutes, don't impact ganglion cell health. But short term fluctuations, those that occur over different days at different times of the day. So there was a home tonometer that I had access to in the 1990s, which was an applanation tonometer. We used that in about 760 eyes of patients. We asked them to measure their pressure 5 times a day for 5 days. And then returned the instrument back to us. We found that those had a pressure that was tight over the 5 days, even though the mean was higher, behaved differently than eyes that had a lower mean but the spread out version of their own pressures. And the difference between these two groups was very remarkable. So in other words, our study published in the year 2000 showed that the relative risk of disease progression in 5 years, if an eye had a pressure range of 5.5 millimeters of mercury, was 6 times more likely to progress compared to an eye that had a range of only 3 millimeters of mercury. This is after you bring the pressure down into the normal range. So once the pressure comes down below 20, 21 range, the importance of fluctuations is tremendous. This paper could not be replicated because no one else had the home tonometer, and that home tonometer could not be marketed because it needed topical anesthetic eye drops. But the retrospective studies, analysis of studies was done for the ages, so the advanced glaucoma interventions, and they showed the same thing. That if for 10 years the standard deviation of pressure was less than 3, they did not progress. If it was more than 3, they progressed. And it was more important once the pressure was brought down to normal. This same result was found in the CIGID study, the collaborative interventional glaucoma study. That is, the standard deviation, if it is more than 3, will progress much faster. You got the same results in angle closure. Those with glaucoma had greater fluctuation compared to those who were suspect. We then showed in normal tension glaucoma, SLT was actually a very useful modality of treatment because we found that it doesn't reduce the mean pressure as much, but it reduces the range of pressure. We reduced the range of pressure, though the mean did not change. So what happened is people went SLT for normal tension glaucoma. The pressure, which was 11, now was 12, and the SLT was considered not effective, when it was actually effective because it kept the pressure stable. Now, ultimately, what are we trying to do in glaucoma? Prevent blindness, right? Ultimately, we want the patient before they go blind. It's a sad thing to say that in glaucoma, but that's exactly what we're trying to do. So this is a study that looked at patients progressing to blindness compared to those maintaining vision over 30 years in Olmsted County in Minnesota. The mean pressure was the same. It was the variability of each patient's intraocular pressure that was higher in the eyes that went blind. So this is how we get pressure fluctuations. Sometimes the drop misses the eye. Sometimes we dose it 4 hours late. Sometimes we don't have the medicines. So we get short and long-term pressure fluctuations. Many people ask me, how do I practically manage glaucomas currently? I use these Canadian Society guidelines, which I like because they are relatively easy to follow. For advanced glaucoma, low teens as the target pressure. And to that, I've added my own fluctuation tolerance limits, less than 3, moderate mid-teens, mild high teens, acceptable fluctuation less than 5. What about accuracy? You will say that, hey, we measure the pressure in the clinic. One technician measures at 18, another technician measured it at 15. How do we know which is accurate, which is the correct one? There is already 3 millimeter difference between the two. This was a study that showed that nearly 30% of all Goldman tonometers at an academic medical center had calibration errors. And even after you recalibrated them, they still had calibration errors. So is Goldman tonometry really the gold standard? I don't think so any longer. This was a study done by a colleague of mine, Sam Moray, from Case Western University in Ohio. She looked at what is the amount of fluctuation in normal people. And in normals, it was less than 3 in a majority of them. Then 3 to 5 in a smaller minority, an extremely small minority was more than 5. These were normals. And which tonometer is actually helping really get the correct measurement by repeatability, and the repeatability of the Goldman was 0.68, whereas the repeatability of the eye care rebound tonometry was 0.84. The beauty of rebound tonometry, which is what we have learned, is that it is not operator dependent. It is not subjective. It doesn't depend on the training of the operator, and it doesn't require recalibration. I have no financial interest in this company or its products, so just wanted to clarify. We use this home tonometer to check the intraocular pressure, and much prior to that, we used the animal version. TonoVet was the first instrument that they came out with to check pressures in animals. We used that in patients, and we found that it was really not requiring an anesthetic. And we have since used the home tonometer for managing tough glaucoma patients. Not all, tough. So this is an example. I'll leave you 2 examples. This is an example of a patient with normal tension glaucoma who's getting worse. As you can see, the visual field is slowly encroaching and has already encroached into the inferior paracentral region, which means this patient cannot read out of his right eye. So we decided to do trabeculectomy because pressure is 10 to 12. The patient is not convinced. So he asks us, can you please show me that the trabeculectomy is going to be useful? So we showed him the pressures before trabeculectomy and after trabeculectomy in his right eye. And you can see before trabeculectomy how the pressures are changing. After trabeculectomy, they are virtually flat. Then he said, I want to confirm that my left eye is still having fluctuation compared to the right eye. And sure enough, his left eye pressure is in the green, and you can see how it is fluctuating compared to the previous. So now, wanted to see the difference, right eye after trabeculectomy and left eye before trabeculectomy. So this is the right eye, and that's the left eye. So he had trabeculectomy in both eyes and has been stable since. On the other hand, we had a patient who is a helicopter pilot, and he said, I am getting bad headaches in the middle of the night. I am sure I'm getting angle closure attacks. And I had already done the laser iridotomy for him. And I told him, no, you're not getting, your headache is due to dry eye. I showed him that his OCT was not changing, that it was completely stable, but he was not convinced. So he did home tonometry. He went and bought a home tonometer himself and did home tonometry and came to me with a triumphant look on his face and said, see, I am getting angle closure attacks. See, my pressures are reaching the 30s. And on the face of it, this looks like, yes, he's correct, but he's not. All of his pressure spikes are occurring between 4 a.m. and 8 a.m. He's measuring the waking intraocular pressure spike. So once he wakes up, if he doesn't wait 15 minutes, he's going to measure the spike that occurs in all of us. This is a normal pressure spike that is happening in the middle as soon as you wake up. You see, during the day, his pressures are completely controlled. So this is a false reading. And I'm going to skip this, and I'm going to thank you for your kind attention.
Thank you very much, please, Ajay. Actually, this is an important topic because we all depend on the high IOP. I mean, you are talking about this fluctuation for more than 20 years now, but a lot of us are actually aware of the importance of fluctuation for the control of glaucoma. And now may I call Dr. Mohammed Al-Ashri, combined phaco emulsification with a TSCPC diode laser.
السلام عليكم، صباح الخير. الأول حابب أشكر البورد بتاع الجمعية على الدعوة الكريمة والتنظيم الرائع. النهارده هنتكلم على الكاتاراكت والجلوكوما، علاقتهم ببعض. زي ما احنا عارفين هي دبل فيس، يعني هو كل كاتاراكتس بيشنت فيه جلوكوماتس ايشو، كل جلوكوماتس بيشنت عنده لينس ستيت شوت بي كونسيدر. فالكاتاراكت بيعمل جلوكوما ايضا فاكوليتيك فاكونافلاكتيك فاكومورفيك بوزيشن اوف ذا لينس، او الجلوكوما بتعمل كاتاراكت سواء كان هو associated mobility في الاثنين زي السيلوكسفليشن او حتى المانجمنت بتاع الجلوكوما ممكن هو نفسه يعمل بروجريسيف كاتاراكت. فده بيخلينا دايما في اختيار ما بين ان احنا نعمل فاكو بلس فاكو بس اونلي فاكو. فهو الفاكو بلس بيبقى لها ميزه ان احنا بناخد بالتارجت الحاجتين مع بعض، التو موربيديتيز الكاتاراكت والجلوكوما، بس في نفس الوقت بيبقى لها لونجر ليرنينج كيرف، الفيجوال ريهابيليتيشن والريكفري بتاع البيشنت بيبقى اقوى. ممكن يبقى فيه كومبليكيتد ايشوز على البليب والبليب بروبلم والحاجات دي. في المقابل طبعا الفاكو اونلي بيبقى مغري جدا عشان هو كومن اوبثالميك براكتس، جنرال اوبثالميك براكتس، الفيجوال ريكفري بتاعه سريع، الريهابيليتيشن بتاع الفيجن بيبقى اسرع، الفولو اب بتاعته بتبقى محفوظه لحد كده. بس برضه نتفق انه لم يعد من المقبول is not accepted at all ان احنا نتجاهل تماما to ignore الجلوكوما advanced glaucoma in cataractus patient, to ignore lens state with significant cataract in glaucoma patient. طبعا بيبقى فيه شويه كونسيدريشن وشويه حاجات مختلفه في العيانين بتوع الكاتاراكت مع الجلوكوما زي اليوفيتس، زي السيلوكسفليشن، الانجل والانجل كلوجر بروبلم، البوست اوبراتيف اي او بي سبايك اند هاو او بي سبايك، بري اوبراتيف اند اوبراتيف باي انجكشن او حتى بوست اوبراتيف. الاختيارات اللي بتبقى قدامنا ايضا الفليكتومي والفاكوترابيكيولوتومي او الفاكو مع الديود اللي هو الموضوع بتاعنا النهارده. الفاكوترابيكيولوتومي تو بي ديسكاسد، يعني مش هو ده محل الحديث النهارده، وفيها طبعا ويل واجينست وان سايد وتو سايد والعيب بتاع كل حاجه. الانتي ميتابولايتس اللي بقت مانداتوري فور اول بيشنت with glaucoma، الفكره في الريسك كالكوليشن اند هاو تو اكسبوز ذا بيشنت فور اند كونسنتريشن اوف ذا مايتومايسين او اي انتي ميتابولايت. فورنكس بيز او ليمبر بيز. الفاكوترابيكيولوتومي ده ريسنت تكنيك واللي بقى لها دلوقتي برود سبيكترم للابلكيشن حتى مع الحالات مش بس تو مايلد تو مودريت جلوكوما، انما هي بدات تاخد نصيب في حالات الادفانس جلوكوما كمان از انجل سيرجري عموما. طبعا في ايشوز عليها مع الانجل انوماليز ومع الانجل كلوجر، انما هي ستيل هاز ا بروميسنج بليس. انما موضوعنا النهارده عن الفاكو مالتيفيكيشن مع الترانسسكليرال دايود ليزر. والمقصود بالترانسسكليرال دايود ليزر اللي هو السب سايكلو او المايكرو بالس او السب ثريشولد. طبعا هي الموضوع تو بي ستادد ييرز بيفور في كذا ستادي. الافكت بتاع الفاكو مالتيفيكيشن زي ما احنا عارفين ان هو بيزود الانجل ويدث وبيزود الانتيريور تشامبر ويدث، في نفس الوقت بيزود الدرينج بتاع الانجل وبيقلل الانترا اوكولار بريشر، وكل الحاجات دي بتتناسب عكسيا مع وضع العين قبل العمليه. يعني كل ما كان نارو انجل كل ما كان الريزلت احسن. برضه في ايشوز كانت الحاجات دي ريزيست ولا ترانزيانت لمده قد ايه على حسب الاناتومي بتاع العين، اذا كان هو مايوبيك اي ولا ايمتروبيك اي ولا هايبروبيك اي. النتائج طبعا احسن واطول في الحالات الهايبروبيك اي. احنا بنتكلم على الافكت بتاع الفاكو الون. لو جينا ضفنا عليه الافكت بتاع السب ثريشولد او المايكرو بالس او السب سايكلو، هو ما هوش سايكلو ديستراكتيف قد ما هو بيعمل سم سورت اوف بايو موديوليشن للسيلياري بروسيس، وده من شأنه ان هو يتشينج الاناتومي بتاع الانجل ويزود الانجل ويدث ويزود الانتيريور تشامبر ويدث برضه. فعشان كده الاثنين مع بعض بيبقى لهم افكت كويس، خصوصا مع الهاي سوفت بروفايل واللو كومبليكيشن بوسيبيليتي مقارنه بالفلترنج سيرجري او الانجل سيرجري. طيب العيانين دول احنا عملنا لهم بري اوبرتيف ايفالويشن عادي خالص، فيجوال اكيوتي، انتر اوكولار بريشر، ريكوردنج للبري اوبرتيف ميديكيشن كلهم. قبل العمليه بنخدرهم بانتي ميتابولايت سوري اسف انتي بيوتكس، توبيكال انتي بيوتكس، وبنخليهم ماشيين على على الميديكيشن بتاع الجلوكوما خوفا من البوست اوبرتيف اي او بي سبايك. بعد كده بندخل العيان العمليات وبنبدا نعمل السب ثريشولد السب سايكل او المايكرو بالز، بنعمله 3 مللي من الليمبس، وبعد كده بنعقم تاني وبروسيد فور هابو سيرجري لايك اولويز بدون اي سبيشال كونسيدريشن، مفيش مشكله خالص. بعد كده البوست اوبرتيف تكنيك مهم جدا ان انا اهتم في الاي او بي سبايك، لان ممكن يحصل فاسكولار اوكلوجن سواء كان سنترال او برانش فاسكولار اوكلوجن ارتري او فين. ساعات ندي العيان لو هو يونجر ايج او هو عنده هيستوري اوف يوفيتس ممكن ندي العيان كمان سيستميك ستيرويد بالاضافه الى التوبيكال ستيرويد. الكومبليكيشن ممكن البوسيبيليتي اوف سيستول ماكولار اديما، انتيريور يوفيتس، الميدريزس ترانزيانت او بيرزيستنت. الانفكشن طبعا هيبقى عشان الانفكشن بتاع الفاتو اكتر منها الديود. طبعا الفيجوال اكيوتي ممكن عيانين يحصل لهم، وهتشوف الاستادي ان يحصل لهم ديكلاين، بس هو مش بالضروره يكون الديكلاين بسبب الفاتو الديود، ممكن يكون بسبب النيتشر اوف ذا ديزيز. هنلاقي الاي او بي بنسبه كبيره اذا كان بسبب الفاتو ولا بسبب الديود. برضه بالنسبه للفيجوال اكيوتي نص العيانين اتحسنوا في الفيجن، النص الثاني نصهم بقى اللي هو الربع الفيجن قل سطرين عن اللي كانوا داخلين بيه قبل العمليات. بالنسبه برضه للانتي جلوكوما دروبس نزلت صنف او اثنين. وفي النهايه احب بس كومبايننج الترانسيس سبتليول دايود ليزر مع الفاكو ممكن يكون افكتيف. الايرلي بوست اوبرتيف كومبليكيشن شود بي مانجد بروبرلي اند ايرلي، وطبعا الموضوع محتاج further research and further study. Thank you very much for your attention.
Thank you very much, Professor Hashim. And actually, this highlights the common role of subthreshold diode. It's actually will be more and more. Thank you very much for your wonderful lecture. معلش نطلب من الساده المتحدثين ان احنا قد ما نقدر نتكلم بالانجليزي عشان غير الضيوف معانا كمان حضور الاجانب، فان شاء الله كلنا نتكلم بالانجليزي باذن الله في كل المحاضره بتاعتنا. And now I ask for dear friend Professor Ahmed Hassan from Alexandria to talk about dry eye and
everyone. My talk today is about dry eye and glaucoma. What is dry eye disease? It is an ocular sensory disease characterized by hyperosmolarity and tear film instability that can cause discomfort, fluctuating vision, and potentially to ocular surface disease. How common is the problem? Dry eye disease in general observed is about 10 to 30%. Patients with multiple drugs, often 40 to 60% have dry eye disease, which are symptomatic. Also, the higher ocular surface disease scores with more prevalence, especially with back. What is the symptoms? Patients complain of dryness, burning, fluctuating blur, foreign body sensation, worse later in the day after drops, reduced contrast and vision quality, which affects the face, driving and reading, and affects the adherence of the patients. Patients stop or miss time drops when eye stings. How to examine the patient with dry eye disease? First, we look for the pneumonia gland expressibility. We look for the tear nemesis, presence or absence of dermis. We test for tear breakup time. We use showing, and lastly, we look for conjunctival and corneal staining properties. The tear breakup time, if it's less than 10 seconds, this is unstable. If it is less than 5 seconds, it is severe. Schirmer test, if the patients show wetting less than 5 millimeters within 5 minutes, this suggests aqueous insufficiency. Staining patterns relate to the site, especially in dry eye disease. The staining pattern is the interpupillar area. If it is inferiorly, this is related to blepharitis. If it is superior, mostly it is frictional from the conjunctiva. In a large study, 52.6% of glaucoma has had a diagnosis of dry eye disease. What is the relation? You have to see the relation between the topical anti-glaucoma medications and dry eye disease, the topical anti-glaucoma medications and meibomian gland dysfunction, and the topical anti-glaucoma medications and ocular surface inflammation. Greater number of anti-glaucoma medications and duration of therapy was found associated with abnormal corneal staining, shorter tear breakup time, and tumor test less than 5 mm. All are suggestive of dry eye disease. Meibomian gland loss has been associated also with anti-glaucoma medications, which is relevant given that meibomian gland function itself may contribute to dry eye disease. There is evidence also indicating the eye receiving anti-glaucoma medications have increased ocular surface expression of inflammatory markers. Of course, we all know the role of preservatives, especially benzalkonium chloride, which correlated with worse corneal epithelial punctate erosions and shorter tear breakup time. Not only the medications for glaucoma, which lead to dry eye disease, also surgical interventions like capsulectomy, it was found with reductions in tear breakup time and increase in corneal staining, mostly due to Dennen formation. So how to manage this problem? First, we can modify our glaucoma therapy. Switch preservative-free anti-glaucoma medications. Use fixed drug combination to diminish the number of drops used. Consider laser mix or incisional surgery, or use modified glaucoma drug delivery system as was discussed before. Then we have to treat the dry eye disease itself. We use preservative-free ocular lubricants, topical anti-inflammatory therapy like typical steroids for short treatment. If we're going to use long-term treatment, we can use cyclosporin A, tear conservation with punctal plugs, and nasal spray tear stimulation. Then if you have meibomian gland dysfunction, we aim meibomian gland targeted therapy like antibiotics, meibomian gland expression, thermal pulsation, intraductal probing, and intense pulsed light. As we mentioned before, we can go for alternative drug delivery system for glaucoma that's a dropless future. These are some types of alternative drug delivery systems, as discussed before. To conclude, dry eye disease occurs at a higher prevalence in individuals with glaucoma than in individuals without glaucoma, mostly related to the therapy for glaucoma. Assessment and treatment of dry eye disease in patients with glaucoma is extremely important to prevent ocular surface damage, improve quality of life, and facilitate treatment adherence to anti-glaucoma medications. As such, patients with glaucoma surely benefit from an evaluation for dry eye disease. Management of dry eye disease include modification to anti-glaucoma medications and the use treatment of dry eye disease. Thank you for your attention.
My dear Professor Ahmed, thank you for this nice lecture. It's my pleasure to introduce Professor Dr. Muhammad Mahdi. He will talk about positional IOP changes.
Thank you very much for giving me the chance to talk about intricacies on the intraocular pressure and the positional changes in the intraocular pressure, which is a little bit strange topic that I find it very important to raise attention towards this one. But before going to know what is going on with position change in intraocular pressure, we have to understand the mechanism of regulation of intraocular pressure. Normally, the intraocular pressure is regulated mainly through regulation of aqueous humor volume in the anterior chamber. The increased intraocular pressure in non-glaucomatous subject get compensated by choroidal compression, scleral expansion, and accelerated aqueous outflow. In contrast, patients with chronically raised intraocular pressure have reduced compensatory capacities as explained here. Hence, glaucomatous eyes with extended exposure to increased intraocular may have show intraocular pressure correction upon position changes. An increase in the central venous pressure upon placing the patient in the same position decrease the flow and increase the pressure within the periocular venous system. There is a compelling evidence that large diurnal fluctuation in intraocular pressure often leads to missing peaks of elevated intraocular pressure, which might lead to misclassification of some kinds of primary glaucoma to be misclassified as normal pressure glaucoma, despite the fact that they are high intraocular pressure glaucoma with spikes. Elevated nocturnal intraocular pressure in the supine position may be a risk factor for glaucoma's progression in patients with normal pressure glaucoma. The influence of body and head position in the intraocular pressure. Intraocular pressure can be altered by changing both body and head position. The magnitude of intraocular pressure changes varies according to the angle of between plus 90 in the standing or the upright position or plus 90 in the inverted position and the duration of exposure. It seems to be influenced by the presence of glaucoma as well. In this study summarized a lot of papers that has addressed this issue and comparing the non-glaucomatous and the glaucomatous patients. Here we could find that Bartley found that there is non-glaucomatous subject expressed positional changes between the settings and the supine position less than 2 millimeter mercury as compared to more than 2 millimeter mercury in the glaucomatous patient. And Takehara found that there is a changes between 5.6 millimeter mercury in the non-glaucomatous patient and 8.6 millimeter mercury in the glaucomatous patient as well. And also Carlson found that there is a difference between the supine position between the 15 degrees tilt and the 50 degrees tilt between 11 millimeter mercury. Also, Linder found that there is this threefold increase in the intraocular pressure between the supine and the inverted position as well. Warren et al. Found that there is 16 millimeter mercury increase in the intraocular pressure in the inverted position, like the yoga position here, which is, of course, more increase in the glaucomatous patient here. If we can see here that this is the baseline sitting position, and if we stand on the head, we find that this twofold increase in the intraocular pressure immediately after standing on the head, that's maintained after 5 minutes and immediately regains it to the normal intraocular pressure after getting to the upright position again. The effect of different head position on the lateral occipital position has been addressed in this paper, and they conclude that low head position elevates the intraocular pressure of the dependent eye in medically treated open angle glaucomas. Adjustments the height of the pillow might help to mitigate intraocular pressure elevations resulting from lying on the side with low or no pillows in glaucoma patients. In this paper here, we can see that in the sitting position here, the difference between the right eye and the left eye, there's no difference. and the supine position as well, there's no difference here. But in the supine position, there's little increase, which is not significant. But if we came here to the right lateral decubitus position, we find that there's significant increase in the intraocular pressure from the sitting to the lateral decubitus position from normal one. And left decubitus, there is increase in the intraocular pressure in the left eye as well. And with Broom position, with right head tilt, we find that the left eye, which is the dependent eye, is increase in the intraocular pressure, and vice versa for the right eye if we have a left head turn. And we can see here, if we have the patient in the normal recumbent position here, and this head elevation with a high below little bit, and this is with a no below, we can see here that a high head position has a lower change in the intraocular pressure, and the no below we have you see here that this increase in the intraocular pressure about 4 to 5 millimeter mercury. Of course, all of us could understand how to measure the intraocular pressure in the recumbent position, and we can see here that we can measure it even with the Goldman ablation tonometer using the ablation tonometers, Goldman one. There is a comparison between the different machines used for measuring the intraocular pressure using the Goldman ablation tonometer, eye care, pneumotonometer, and tonoban. And we found in this study, they found that the Goldman ablation tonometer and the pneumotonometer are the best ones to measure the intraocular pressure in the different position here. As you can see, because there's little difference between them. What is the relationship between progression of visual field damage and the positional change in the intraocular pressure? In this article, changes from the sitting to the upright position to the horizontal lying down position, we found that here that normal pressure glaucomas are more affected than high pressure glaucomas, and the patient. The intraocular pressure measurement in the horizontal position should be included in the elevation of these patients. The magnitude of pressure-induced intraocular pressure changes and glaucoma damage, the greatest intraocular pressure variation occurs in eyes with more advanced damage. Eyes with more advanced damage has more elevation in the intraocular pressure in the supine position or the lying down position. So progression of visual field damage in normal tension glaucoma be associated with intraocular pressure in the horizontal position and the magnitude of intraocular pressure elevation accompanying changes. So both reports suggest that damage to the optic nerve head in glaucoma might occur when patient is lying flat during sleep. Headstand yuga position or sirsana position as we call, a mean increase in the intraocular pressure between about 15 millimeter mercury, or at least double or sometimes triple, as explained by Robert Weinreb in the studies I have shown earlier here. What is the effect of systemic and ocular factor associated with bushel changes? Our patients with glaucoma are usually hypertensive and diabetic, or has autonomic dysregulation. These patients are more affected with the positional change in the intraocular pressure, and the change in the intraocular pressure is much greater in the autonomic failure patient. That's why they exhibit about 8 millimeter mercury plus or minus 6 millimeter mercury compared with 1 or 2 millimeter mercury in normal subject. What to understand from this quote, it is important to consider the fact that definite relationship between intraocular pressure and the body or head position when managing glaucoma patients, especially those with advanced disease, in addition to diabetic and hypertensive patients as well. And it is the same idea as this patient with heart failure. An intraocular pressure measurement in the horizontal position should be considered in the elevation of glaucoma patient, in evaluation of glaucoma patient. Also, understanding this mechanism might help to mitigate the problem of intraocular pressure fluctuation and the progression of glaucoma patient is the proper control. Thank you very much.
Okay, thank you very much, Dr. Mohammed. Actually, this is interesting. And why do you think the pressure can rise when you are sitting and then you stand up? Actually, you would expect the reverse. Okay, not standing. Okay. I think that paper of ophthalmology, you were mentioning that he was sitting and if he stands up, the pressure rises? No, I understand. Okay. Okay, thank you. And we have maybe a couple of minutes more. May I ask Professor Wong about the drug delivery system as a simple glaucoma practitioner in the world? Of course, I know it varies from one area to the other, but these drug delivery systems can prevail. A few years back, we had, for example, some studies in Egypt, and then it disappeared, at least in Egypt. So what do you expect for the future of the simple glaucoma practitioner of these drug delivery systems?
Thanks for the question. I think really, like I said, it has to be something that's real world. It has to be something that people are going to use. It's going to be adopted. So it's got to be cheap, effective, and it can be well distributed around and convenient for the doctors and patients. So ideally, it should be an office-based procedure where you can just get like people are doing for intravitreal injections. So you just do it in the clinic. Maybe even the nurse can do it for you. But you still get your table code, so the surgeon still gets their fee for doing the injection. And I think that's important that the doctors are encouraged financially to be able to use it, because medications, eye drops, we don't get any incentives. But if it's a surgical procedure or a procedure that you can do in the clinic, then people are more likely to adopt. So that's why that's what I'm looking for, something that is real world and everyone can appreciate it.
So we are still looking for this.
We are, but I think there should be something on the horizon. So watch this space. Thank you.
Thank you. Thank you very much.
I think we have come to the end of the session. I send my greetings to all doctors who gave us nice lectures, and let's proceed to the next session.
بسم الله الرحمن الرحيم.
session اللي هو كان فيه segment positive iris angle and lens interaction. أدعو الدكتور عبد الحميد الكوفي هيتكلم عن البلوتو ايرس سندروم. Good morning, everybody. Thank you, dear board, for the kind invitation. It's my pleasure to talk today about plateau iris. Actually, you have a dilemma of the angle closure, dilemma in the diagnosis, in measurement of intraocular pressure, dilemma in decision making. However, despite its low incidence relative to the open angle, by 2040, the number will jump from 23 to 32 million. The EAGLE trial gave us a solution for the lens extraction. However, the inclusion criteria for the EAGLE study didn't include all the platform of the narrow angle. So we have the plateau iris, which is a subtype of narrow angle with a lot of unanswered questions. It is an anatomical configuration with the iris either flat, inserted on the ciliary body, or with rotation or displacement of the ciliary body processes leading to a goniotrabecular closure, which is either oppositional or synechial. Definitely, the laser peripheral anatomy is an incomplete solution. That's why we define plateau iris based on the LPI. If it is without LPI, it is just configuration. If it persists after LPI, it is syndrome. So we define a non-pupillary block angle closure. By slit lamp, it does not follow the Van Herrick, so the anterior chamber is not shallow, yet it is diagnosed only by gonioscopy. And as we mentioned, LPI does not change the AC configuration as it occurs in the pupillary block. So the central AC is deep while the draining angle is occluded. The prevalence in Egypt is not very well documented. However, there is a study in 2022 in El Gharbiya. It showed similar prevalence to the worldwide and Singaporean studies, which showed about 30% prevalence by UBM in primary angle closure more than 50 years. A short review in states also showed prevalence to 50%. It's increasing in Caucasian. It occurs in younger age group up to 12 years old, more in females and less hyperopic with positive family history. Still diagnosed for any type of glaucoma with gonioscopy. The double hump sign with the indentation gonioscopy makes it more evident. It's observed more in the superior and inferior quadrants. The presence of iris bombay in some quadrants does not exclude plateau iris configuration in others, so LPI is important. It's either complete or incomplete according to the level of iridotrabecular closure, whether reaching the Schwalb's line or not reaching the Schwalb's line. To discriminate between oppositional and synechial, we need more intense, more forceful gonioscopy. Based on UBM images, we have 5 criteria which might be present in single quadrant, 2 or 3 or 4 quadrants. The ciliary processes, which is very important, and it is the tissue to be targeted while treated, are directed supporting the peripheral iris, and the iris root has a steep rise from its point of insertion, followed by a downward angulation with a central flat iris absent ciliary sulcus, and with irido angle contact above the level of scleral spur, as we see here. For diagnosis, we need at least 2 quadrants should fill the above criteria. Ultrasound biomicroscopy images of the same eye were evaluated before and after LPI using the same criteria. it might occur with a thick iris or a thin iris. The management, definitely the argon laser peripheral iridoplasty might be of benefit in the oppositional type. It takes the iris away from the angle. Also, the endocycloplasty or endocyclocoagulation is the way to target the ciliary processes which are responsible about the iridotrabecular occlusion. Under vision diode laser used to reduce the size of the ciliary processes, leading to some sort of cycloplasty, getting the processes away from the angle. It is of benefit in both oppositional and synechial closure, and can be done attacking only half the circumference or the whole circumference, not relying upon the classical pop of the transscleral diode cyclophotocoagulation, and without affecting the intraocular to a hypotenuse levels. The 360-degree trabeculotomy, Prolene guided, together with lens extraction, should be of benefit, especially in more than 3 quadrants synechial closure. The Prolene guided ensures presence of the Prolene inside the canal of Schlemm, and in this case, it happened to be accompanied with an excisional trabeculotomy, partly during the pulling of the Prolene, and maintaining the trabeculodescent membrane ensures not converting the procedure to a penetrating procedure. And this is how the part of the trabecular meshwork, which was excisionally done, was removed. Endocycloplasty and lens extraction in treatment of severe plateau iris syndrome, treating the ciliary processes with diode laser using the endoscopic approach, seems to be primarily a result, the effect seems to be primarily the result of laser treatment in combination rather than the lens extraction alone. Comparing the effect of lens extraction with endocycloplasty to lens extraction alone showed that it's more effective to be combined than lens extraction alone. This study compares both and gives us the insight that lens extraction, which is the main method in EAGLE trial, will not be enough in 30% of the cases of chronic narrow angle. We should exclude other causes of ciliary body edema. Unanswered questions: does plateau iris syndrome occur in attacks like the traditional pupillary block? Yes, I think. Does mydriatics and dark room situation precipitate attacks? I think yes. Also, it needs studies to answer this question confirmably. IOP does elevate before and after dilatation with patent PI in presence of plateau iris. I think also it occurs. Does plateau iris syndrome explain the persistent elevated IOP in pseudophakics primarily operated for chronic narrow angle? Yes. Is aqueous misdirection a considerable risk? Yes. Should we include myotics again in our prescriptions? Maybe. This is an example of a case managed by Paul valve for plateau iris, and the valve is not apparent because of the lost AC post-operatively because of aqueous misdirection, and with traditional IZH successfully deepens the anterior chamber again, and as we can see, the valve is apparent and the anterior chamber is deep. The prophylactic IZH can be done only if aqueous misdirection did occur in the previous eye. Thank you.
Thank you, Dr. Abdelhamid, for this nice presentation. I would like to ask Dr. Arsani to present his talk.
In glaucoma, we have few opportunities to be able to prevent glaucoma. Because ultimately, there is no treatment. We can't cure glaucoma. We can stop its progression once it starts. But there are very few things we can do that can prevent glaucoma. And this is one that I'm going to talk to you about today. So this is a 49-year-old African-American male who is referred for a pressure of 42 in one eye and 28 in the other eye. He is a diabetic, undergone recent weight gain. He's been diagnosed as a glaucoma suspect for many years because of large cups and myopia. And he's got, minus 225, 125. He's got a angle that was diagnosed by my fellow as open 360 degrees to ciliary body band. And you can see the cup is 0.8 in the right eye, 0.65 in the other eye. So it looks like primary open angle glaucoma. And if you look at the visual field, you can see the distinct difference between the two eyes. The OCT, and you can see that the nerve fiber layer thickness in the right eye is completely extinguished, and also the macular thickness. This is the gonioscopy done by my fellow, and you can see here if there is a possibility of reducing the light in the room. Can we reduce the light? Dim the light, if possible. You can see that the angle does look open. You can see the trabecular meshwork, you can see the scleral spur. And the real gonioscopy is not that. The real gonioscopy, there is no angle structure seen. This is the real gonioscopy. You can see that the iris is convex, and the fellow gonioscopy, the iris is flat. And there is a distinct difference between the two findings. We did a laser iridotomy, and there was a significant gush of fluid relieving pupillary block, and his pressure is not just controlled on 1 drop of latanoprost in both eyes. So these landmarks that we look at, the trabecular meshwork, the scleral spur, the ciliary body, they are not easy for us to see. So if you look at this picture here, you can see the landmarks, but it is very easy for us to mistake one for the other. And these mistakes happen in the MIGS surgeries, which is what causes all the problems like cyclodialysis, iridodialysis, and things like that, because we are not able to identify these landmarks. This problem also occurs in SLT, where many times SLT is done to the Schwalbe's line, because the pigment is there, and the trabecular meshwork, there is no pigment. No wonder the SLT is not effective. If you look here, you can see at one edge, the angle is open, the other, it's closed. So in the same quadrant, you can have a closed angle and an open angle. This is the terminology we use today, which is the primary angle closure suspect, where the scleral spur is not seen for more than 180 degrees, with no indentation, with eye in the primary gaze. And then there is PAC with synechia, PAC appositional, and then last is with damage to the optic nerve. The typical damage that you see of the optic nerve is a mild yellow color. You may be able to recognize there is a little yellow tint in this optic nerve. It's a mild pallor. This is indicative that this eye has had a large pressure spike. It is an ischemic damage to the capillaries in the optic nerve head. So this is a classic finding in chronic angle closure glaucomas. They may not give you a history of the same, but once you see this, you know. You can see the convexity of this iris. We call this the Mount Fuji appearance. Based on a volcano in Japan, the Mount Fuji appearance. There is volcanic expectation. Now, open angle glaucoma has been called 5 times more prevalent
than chronic angle closure. But chronic angle closure causes 3 times more blindness. Half the world's glaucoma is caused by chronic angle closure. And 22% progress from suspect to angle closure, 30% from closure to glaucoma. Who are the usual suspects? Who are the ones we need to look at more carefully? Diabetics. So what is happening is, why do I call it a missed epidemic? Because of the amount of refined food that all of us are eating, most of us are reaching what is called pre-diabetic state around the world. And this is resulting in sorbitol being produced by the body that gets inside the lens, pulls fluid with it, the lens swells, and that is causing intermittent angle closure. Patients who have a history of vein occlusion, anybody who has a branch retinal vein occlusion or a central retinal vein occlusion, if the eye is phakic, invariably they will have occludable angles. The cause of vein occlusions is highly preventable if you can identify angle closure. These eyes, unfortunately, because hyperopic, they have small nerves, and these small nerves are crowded with blood vessels in them. And any spike of pressure causes them to have a vein occlusion. East Asians, of course, Vietnamese are the ones with the highest incidence, loose zonules in pseudoexfoliation, large pupils, and cataracts. Now, remember that open angle glaucoma can develop narrow angle as the lens thickens with age or the blood sugar. An old narrow angle glaucoma after cataract surgery, because of damaged trabecular meshwork, can masquerade as open angle glaucoma. But the biggest thing I want to point out to you is the intermittent touching of the trabecular meshwork by the iris in dim lighting damages the trabecular meshwork, ultimately results in the development of glaucoma. So if we can prevent this intermittent touch of the iris to the trabecular meshwork, we may be able to prevent future glaucoma. So we can do certainly a laser iridotomy, but sometimes even after the laser iridotomy, because it is phacomorphic, this is touching the trabecular meshwork. If there is a family history of glaucoma, I typically put these patients on pilocarpine, 1 drop at night, 1%, 1 drop before they go to bed. This is to prevent the pupil from dilating and touching the trabecular meshwork. And this doesn't cause chronic pupillary constriction, but it prevents glaucoma. So, what is the increased awareness? Gonioscopy has tremendous limitations, like the slit lamp, and accommodation constricts the pupil, artificially opens the angle, causing more angles to be called open angle. These errors occur when patients have large pupils in the dark room. The von Herrick test, which is a test most people disregard because it has been maligned in our literature as not being accurate, is actually very accurate in all races except Africans. Africans and African American, the von Herrick test is not accurate. All other races, if the von Herrick is showing you that the chamber is narrow, that angle is occludable typically. The reason is that the von Herrick test does not allow light of the slit lamp to touch the pupil. Therefore, the pupil is in its natural state. But what's the critical thing that I'm going to leave you with is 10 seconds. Just remember this. Once you put the gonio lens on the eye, the pupil constricts, angle opens. Even if there is no light on the pupil, if you wait 10 seconds, the pupil returns to its mid-dilated state, collects under it, and elevates in the periphery, causing that same angle that looked completely open, now completely closed. Therefore, after you do the waiting of the 10 seconds, do compression gonioscopy, because only then you can detect the synechia. Here is, you can see the synechia in the angle. Here is an angle that looks open, but it's not open. What you're seeing is the Schwalbe's line. It's a pigment Schwalbe's line. That is not the scleral spur. It's only if you compress that you realize that there is another white line behind the real trabecular meshwork. So how do we treat? Of course, you heard about plateau iris. For pupillary block, we do laser iridotomy. For unilateral angles that are narrow, make sure you don't have an intraocular tumor. And if there is a posterior pushing mechanism, such as malignant glaucoma or scleritis, you need cycloplegics like atropine. Also, iridotomy size is critical. If you don't make the iridotomy a minimum 250 microns, it is not effective. So therefore, make sure that iridotomy is not this small. It has to be minimum 250, and in diabetics and in uveitis, 350 microns. Creeping angle closure, posterior pushing mechanisms. Another point I want to leave you with is, if you see a picture like this, patients with uveitis, 360-degree synechia, no glaucoma. This is the patient at this stage that needs a laser iridotomy. Because this is uveitis, the patient is not producing a lot of aqueous. If you have the patient treated with steroid, patient will produce aqueous, there is nowhere for the aqueous to go. And this will cause iris bombay because the pupil is closed. So this is the time to do the laser iridotomy. And with anterior segment CT, now we are able to see these structures, the angle very clearly, as you saw in the first talks on the anterior. This is in 2006. We had used the swept source OCT to give you almost light microscopy of the angle structures. And as you can see, these are examples of the iris against the trabecular meshwork. You can see how big the iris is and how small the trabecular meshwork is and how it is blocked. This is a pupillary block. This is a plateau iris. This is a combination of the two. So in conclusion, always do the von Erich test. Think why the patient is developing raised pressure. Correct classification for clinical trials. And prophylactic laser iridotomy has the potential for preventing intermittent angle closure. Thank you very much.
Thanks, Professor Asrani. And now may I invite Dr. Samah Fuad to talk about the mimics of angle crisis.
Good afternoon, dear professor and colleagues. I will talk about mimics of angle closure crisis. By definition, acute angle closure crisis, it is a severe ophthalmological emergency caused by sudden obstruction of the angle of the anterior chamber, which resulting in a rapid painful increase in intraocular pressure. It is typically manifested by ocular pain, headache, blurred vision, and halos. Ocular signs as cellular injection, conjunctival congestion, corneal edema, shallow anterior chamber, mid-dilated reactive pupil, high elevated intraocular pressure, hyperemic optic disc, oponioscopy, closed angle. There are several conditions that are maybe acute angle closure crisis, which divided into pupillar block or without pupillar block. Pupillar block such as microspherophakia, morphine, intumescent cataract. Without a pupillar block, further categorization, either pulling mechanism or pushing mechanism. Pulling conditions that pull the iris forward to be contact the trabecular meshwork, pushing mechanisms which push the iris behind. I will present 4 cases that have typical presentations such as acute angle crisis, but each case has different mechanism and management. Firstly, 21 years old female had a history of right cataract surgery 1 month ago, presented with typical features of acute angle closure crisis, with 360 posterior synechia. Fundus was normal. We excluded the presence of choroidal detachment or suprachoroidal hemorrhage. The diagnosis of aqueous misdirection was established. Patient scheduled for anterior vitrectomy, peripheral iridectomy, and posterior synecholysis. Barcelona bore was placed, followed by corneal synthesis. Shallow anterior chamber is relevant here. Injection of viscoelastic. Synecholysis was done. Followed by peripheral iridectomy using vitrector to communicate the two compartments, posterior and the anterior chamber. And doing posterior capsulotomy, anterior hyoidotomy, anterior vitrectomy to release the trapped fluid in the vitreous space. The end point of the surgery is deepening of the anterior chamber. Post-operative 6 months. Aqueous misdirection is a rare challenging form of secondary angle closure glaucoma. Presents with very intraocular pressure, uniform shallowing of the central and peripheral anterior chamber. It is a diagnosis of exclusion. We must exclude choroidal hemorrhage, suprachoroidal attachment, and glomerular block mechanisms. The exact mechanism is unknown. It is thought to be multifactorial. The condition has been thought to result from anterior rotation of the ciliary body, posterior misdirection of the aqueous, blockage of the forward aqueous flow. It is commonly following the ocular surgery, most common with cataract surgery and trabeculectomy. This picture showing UBM and showing the anterior rotation of the ciliary body and the iridocorneal touch. As regarding management of aqueous misdirection, the aim is to restore the normal anatomical relationship between the ciliary body, iris, and the lens to restore the anterior flow of the aqueous and controlling the intraocular pressure. Starting with medical management, intensive psychobasics to tighten the tenules and pulling the lens backward, aggressive aqueous suppressant, hyperosmotic agents, corticosteroid to limit inflammation and ciliary body edema. Never use myotics in such conditions. Currently, the treatment is shown in aphakic and sophophakic cases. Several laser procedures may be done in the same session and the same site, such as laser iridotomy with anterior hyoidotomy and posterior capsulotomy. Laser photocoagulation may be used also. The definite management of aqueous misdirection is the anterior vitrectomy via Barcelona approach to disrupt the anterior hyaloid phase and release fluid trapped within the vitreous. May be associated with iridotomy hyoidotomy to reduce recurrence synecholysis. Going to the second case, a 39-year-old female presented with headache and left severe ocular pain, redness of 3 durations. Typical features of acute angle closure crisis: fundus was hazy, ultrasound was done, showing vitreous hemorrhage and choroidal mass. MRI with contrast, revealing features suggesting intraocular choroidal neoplastic lesion. Patient was referred to the mini oncology center for further systemic evaluation. DET scan was done and revealing bronchogenic carcinoma. The mechanism of angle closure is determined by size, location, and pathology of the tumor, disruption of the barrier and inflammation that result in anterior synetia and anterior segment neovascularizations. Again, female patient, 44 years old, presented with bilateral acute ocular pain, blurring of vision, severe synetia, severe headache. The patient had history of systemic medications of depression. Presented with bilateral typical features of acute angle closure crisis associated with acute myopia. Refraction in the right eye was -4 and the left eye -5. The ultrasound was normal. The diagnosis of drug-induced secondary angle closure glaucoma was established in this case, characterized by bilateral acute myopic shift with acute angle closure. It appears to be idiosyncratic response to systemic medications. Topromate is the most frequently reported drug. Mechanism of drug-induced second angle closure glaucoma may be bipolar block angle closure glaucoma sympathomyelitics or non-bipolar block that result in thickening and forward movement of the lens iridophram, forward rotation of the ciliary body, and ciliocoroidal effusion. Once the drug-induced secondary angle closure glaucoma was diagnosed, immediate discontinuation of the inciting the medication must be done. Initiation of medical therapy, echo-suppressant, systemic corticosteroid may hasten recovery. Aggressive cycloplegia deepens the anterior chamber. The angle closure usually resolves in 24 to 48 hours. Myopia resolves within 1 to 2 weeks. Last case, 65 years old male patient, diabetic, hypertensive, 20 years ago, presented with right acute ocular pain. Typical features of acute angle closure crisis, but here we noticed the rebosis iris. Ultrasound showing vitreous hemorrhage. Neovascular glaucoma was diagnosed. As regarding the neovascular glaucoma, it is a severe form of secondary glaucoma characterized by proliferation of fibrovascular tissue in the anterior chamber, caused by a variety of conditions that involve retinal or ocular ischemia and inflammation, most commonly diabetic retinopathy, central retinal vein occlusion, and ocular ischemic syndrome. Secretion of angiogenic factors, especially VEGF, from ischemic retinal tissues may develop new vascularization in the anterior chamber and produce new vascular vessels in the angle. Three stages: pre-rebosis stage, rebosis, secondary open angle glaucoma stage, finally secondary angle closure glaucoma. Because of the poor prognosis, prevention and early diagnosis are essential in neovascular glaucoma. In central retinal vein occlusion, new vessels in the angle develops without new vessels or rebosis iris. So the gonioscopy is important for earlier diagnosis. As ocular ischemia is the main pathology in neovascular glaucoma, PRP is considered the definitive management, especially in clear medium. In addition, intravitreal anti-VEGF therapy improves the success of subsequent glaucoma surgery, eliminating the angiogenic stimulus, decreasing the risk of hemorrhage at the time of the surgery. Surgical management regarding trabeculectomy, it has the advantage of lower postoperative intraocular pressure compared to the echo shunts, but the bleb failure is common. Echo shunts has avoiding the necessity of surgical iridectomy, photocoagulation reserved for cases with poor prognosis. Take home message: although acute angle closure crisis is a vision-threatening condition, early diagnosis, adequate management can stabilize the disease and minimize vision loss. Thank you.
Thank you, Dr. Asma, and I will present Professor Ahmed Hussain, cataract extraction in filtered eye.
Good morning. I'm going to speak about cataract surgery in a filtered eye. I'm going to speak about the effect of cataract extraction of intraocular pressure and function of bleb, intraoperative factors, preoperative counseling, intraoperative tips for minimizing the risk of bleb failures, and postoperative care. Cataract surgery in patients with pre-existing glaucoma presents a number of potential challenges, particularly for those patients who have undergone prime filtration surgery such as trabeculectomy. Although mechanism of bleb failure after phaco modification is fully understood, the formation of scar tissue as conjunctival scleral flap interface probably presents a greater barrier to effective filtration. Additionally, cataract surgery is thought to cause prolonged low-grade inflammation secondary to lens crystallines. in addition to the effect of ultrasound energy and accuracy leading to further scarring. If we look to the literature, most of the papers say that phacoemulsification increases the need for more number glaucoma medication and increase in the mean intraocular pressure. Another study showed that phacoemulsification reduces the function of trabeculectomy in some eyes. Factors related to low rate failure are previous use of martomycin during TRAP, long time from TRAP to cataract surgery. Also, another study showed that phacoemulsification in trabeculotomized eye lead to failure of the blip. If we look for the intraoperative factor related to the blip failure after phaco, there's incision size, incision site, and duration between trabeculectomy and cataract extraction. As we all know, cataract extraction was done in the past by extracapsular extraction, or small incision cataract surgery, 6, or some people call it mix, and phacoemulsification, either with scleral tunnel or through corneal incision. Studies showed that phacoemulsification with smaller incision is preferable to extracapsular cataract extraction and mix in previously filtered eyes. However, it's important to mention that phacoemulsification after successful trabeculectomy may trigger blip failure, and although phacoemulsification does not neutralize the pressure-lowering effect achieved after trabeculectomy, a permanent increase in intraocular pressure could be practiced. Incision site, either the superior incision or temporal incision. Most studies recommend temporal incision to be away from the blip as possible. However, some studies showed that there is no difference in the rate of blip failure after phaco between superior incision and temporal incision. All the studies agree that the longer the duration is better. Minimal duration between trabeculectomy and phacoemulsification should be more than 6 months. We must counsel the patient before doing phaco in a patient with trabeculectomy about the potential risk of blip failure. The literature estimates that around 10-35% of functional trabeculectomies fail in 2 years period following cataract surgery. Intraoperative tips to reduce blip failure. First, surgical planning to preserve the anatomy and to minimize the inflammatory response around the filtration blip. Topical and intracameral anesthesia is preferable to subtenon or subconjunctival anesthesia to reduce subconjunctival stretching, hemorrhage, and inflammation. Corneal incision should be placed temporarily away from the probe area with good architecture and form. A reduction of phaco machine bottle height and intraocular pressure is desirable to reduce overfill fluid turnover through the blip. Don't be tempted to increase the bottle height to obtain more stable AC. Use intracameral dexamethasone to reduce anterior chamber inflammation in the early postoperative period. 7 pearls when you do phaco in trabeculotomized eyes. Always look for the blip before any cataract surgery. Whenever possible, wait for 12 months at least. Barrett Universal appears the most IOL formula post-trabeculectomy. Avoid trifocal implants. If the patient want to redecanute EDO for extended depth of focus lenses, consider adding subconjunctival 5 uracil to all cases, but you must protect the cornea. Watch carefully between postoperative week 3 and 8 and customize steroid regimen to the needs of the blip. Don't be afraid to protect the blip. Consider steroid or 5-FU subconjunctival injection used in the early postoperative period. Postoperatively, we aggressively treat with topical steroids and non-steroidal inflammatory drugs for 1 month. Maintenance therapy with non-steroidal anti-inflammatory drugs once daily for 1 year after cataract surgery. In the post-operative period, you monitor the blip morphology, not the intraocular pressure. because when the intraocular pressure rises, it's too late to treat. It's the benefit of intraocular injection of 5-FU to the bleb is widespread use. One study found 5-FU has a protective effect on functioning blebs with a lower incidence of postoperative IOP spikes and reduced needs for additional ocular pressure lowering medications. Still, there is no clear message, but the risk of subconjunctival with 5-FU are outweighed by the potential benefits on bleb function. These patients require more frequent follow-up, concentrated around weeks 3 to 8 compared with patients who have phaco alone. Bleb assessment is vital when looking for subtle morphology changes, inflammation, and hyperemia. Don't wait for intraocular pressure to rise as the only sign of potential failure because this occurs late. The ship has already sailed once a significant rise in intraocular pressure has been detected. So it's important to study the bleb morphology better than intraocular pressure measure. Finally, if the bleb fails, we can do revision of the bleb either by external revision or internal revision. Thank you for your attention.
شكرا دكتور احمد. يكون دكتور محمد ابو حامد is tackling the right space where to filter.
Hello again. This time I'll be presenting a case titled Where to Filter, where tackling the right space could make a great difference. First, thanks to my professor and colleague for hearing me throughout the case. Our case is a 55-year-old lady that was referred to our glaucoma unit for glaucoma filtering surgery in her left eye. Medical records has revealed a history of prior acute ankle closure glaucoma 1 month prior that required admission and medical therapy, but no laser or surgery. Her history is significant for diabetes on insulin therapy, complicated with diabetic retinopathy and maculopathy, and prior PRBs and intraretinal injection of anti-VEGF. She's currently on 3 classes of anti-glaucoma medications in her left eye. On examination, the left eye showed a dilated sluggish pupil with a reverse relative apparent pupillary defect. IOP was 16 millimeters of mercury on 3 classes of anti-glaucoma medications. Her examination was also remarkable for mild diffuse stromal corneal edema, slightly deeper anterior chamber, some atrophic iris patches, and an open angle circumferentially pyogonioscopy. Tom's examination showed a slightly swollen disc with a CT ratio of 0.1, besides her diabetic retinopathy and maculopathy. Over the past month, she underwent the following imaging. This is her P-scan, which is largely unremarkable except for some choroidal thickening and floaters. Is showing through an open angles, or the report stated that there might be some angle narrowing and closure with possible double humping and oblated serous sulcus and borderline lens factor. Her A-scan showed a slightly smaller eyes, that much, and this is how she looked at presentation. So considering prior acute ocular hypertension and evidence of optic neuropathy, the borderline lens factor that has only nuclear sclerosis but no glaucoma flecken, the open anterior chamber angle, as we see on the endoscopy, not according to the UM report, being referred for glaucoma filtering surgery, the potential future need for intravitreal injections with or without steroid implants, and it's not a herpetic eye disease that because we had an intact electrical sensation. And after a thorough discussion with the patient, we decided to proceed with trabeculectomy with mitomycin. The surgery was uneventful, including creating a thick sclera flap, a usage of 0.3 mitomycin, a small sclerosing, precaridectomy, 3 visible sutures and 1 central fixed suture, aiming at no flow on table and watertight conjunctival closure. Postoperatively 1 minimal blip, slightly shallow anterior chamber, but yet formed, IB 8, no leak. We added cyclopegia and continued regular treatment of steroids and topical antibiotics. Day 7, the same. Considering the shallow anterior chamber, we administered subconjunctival injection of dexamethasone and atropine. However, on day 14, this is how she presented. Almost lost anterior chamber with some choroidal effusion, IOP of 2 millimeters of mercury. P-scan confirmed the presence of a choroidal detachment and marked largely thickened choroid. So we decided to proceed with urgent anterior chamber reformation and drainage of the suprachoroidal fluid. That was surgery 2, that included AC overfilling with OVD, creating two inferior sclera windows and temporal triangular flaps, partial thickness flaps with partial excision of the sclera bed. So they were actually sclerostomies. This resulted in some drainage of astrocardial fluid, which was satisfactory on table. At this point, we thought, should we address the trabeculectomy site? But because things looked fine, we opted not to, as the less the better. And the anterior chamber was deep, bridge flex intact, good IOP. The scan showed flat choroids. However, on day 7, the AC is again shallow, IOP is low. Despite the mildly elevated blip, there were no leaks, and the scan showed recurrent choroids. So what's going on? And let's have a second look. Have the sclerostomies become closed? Even if that's the case, that shouldn't cause recurrent choroidals if the filtration is adequate. And because the blip didn't seem to be overdraining and there was no leak, and it was not aqueous misdirection if anyone's thinking so, let's review the preoperative data again. This is the left eye, and we can see some supraciliary fluid rim and a significantly thickened scleroretinochoroidal complex. And we were able to remeasure the overall thickness, and it was 2+. And back to the photos of the choroidal detachment, we can actually measure the sclera thickness. So it's a relatively bit thickened, considering that normal values are from 0.95, but not beyond 1.1. What about the other eye? So the other eye didn't have such a supraciliary fluid rim, but the choroid was thickened. And this thickness can not only be explained by the macular edema, but unfortunately we couldn't do a proper EPI or a slip source OST to measure the actual choroidal thickness. But again, these eyes are not small. So what's going on here? We thought that there are two forces that are acting on the choroid. A force that's driving the choroid back to its place, represented by the sclera windows, and another force that's sucking the choroid forward was by the filtering blip. It seems that the filtering blip is more powerful. So we decided to revise the parasclerostomies to ensure their patency and seal the trabeculectomy blip in order to drive the fluid in one direction. This is a very short clip of this surgery. Apologies for being slightly off-center. First, we revisited the parasclerostomies, and the nasal sclerostomy seems to be intact and open. To create more drainage, we reformed the acute chamber of viscoelastic and addressed the temporal sclerostomy again. But sorry, it's not well shown here in the video. Then you closed the inferior periotomy and went to the superior area to seal down the paratrabeculectomy site. It doesn't seem to be overfiltering, as you can see. Removal of the prior reusable sutures, and then adding some extra sutures to close it tightly, as tightly as possible. Not only that, but we thought that adding something to cover it might be of help. So we put a sclera patch graft overlying this. And just to make sure that nothing is going here or there, we use it very tightly with overlying tight conjunctival closure. We're just exploring if anything is here or there. So the next day, there were no blip. The intuition was very deep, IB was normal, and it seems that the choroid is back. Day 7, same. And 6 weeks after surgery, IB is stable with good depth deeper than the other eye. Visual acuity has dropped. And this is how she looked 6 weeks after surgery number 3, with no blip and with a good anterior chamber depth. Comparing the EC depth of the left eye to the right eye, and verified by the UVM, the left eye has a deeper anterior chamber. Even comparing the left eye after the third surgery to prior to the first, after the first surgery to prior to the first surgery, and verified by the UVM is slightly deep as well. Why the patient can see well? Because the cataract has progressed, and despite that, there is a progression of the diabetic macular edema that needs to be addressed. So this is a case of fusion syndrome, which is a condition marked by fluid accumulation to the suprachoroidal space, first coined in 1963, and largely there are 3 main categories. Type 1, which is a small eye with abnormal sclera. Type 2, normal-sized eye with abnormal sclera. Type 3, normal-sized eye with normal sclera. And we think that our eyes represent type 2. In type 1 and 2, the abnormality of sclera occurs due to either obstruction of the vortex vein drainage or because of scleral hyperpermeability. And just as a reminder, nanophthalmic eyes are structurally normal eyes, but they have small anterior and posterior segments, causing secondary thickening of the sclera and the choroid. In type 3, however, the abnormal thickness of the sclera is thought to be related to a pachychoroid disease spectrum rather than a primary scleral pathology. But beware that tubular effusion syndrome is a diagnosis of exclusion and need to exclude a large list of causes. And it has many features as listed here. And the management options include surgical options and medical options. Surgical options such as sclerectomy or aortic vein decompression, or even tracheotomy with endotamponade and internal fluid drainage. Regarding medical treatments, steroids, non-steroidal, prostaglandin analogs, and diamox, or even antiviral injections have been reported. Sclerectomy can be done as a sclerectomy, sclerotomy, or even sclerostomy, and people have advocated using a Kelly dissonance patch to cut or excise a part of the sclera bed, or even use an excision similar to what we do as a filtering glaucoma surgery, or even the usage of mitomycin. In summary, we present a case of tubular effusion syndrome in a non-small eye phenotype, type 2 tubular effusion syndrome that presented initially with acute angle closure, unidentified, unfortunately, initially she underwent reflectomy surgery, but despite being uneventful, with no subsequent lip overfiltration, the eye endorsed serous choroidal effusion. Only drainage of these choroidals has resulted in temporary resolution of them that recurred once the OVD effect has disappeared. This was probably tipped by the passage of any, not only much fluid to the bleb, despite being not overfiltering and the persistent sclerostomies as shown later on revision. Revisiting the trabeculectomy bleb, aiming at complete closure and ensuring the patency of the drainage sclerostomies resulted in complete resolution of the choroidals with no recurrence, and even slight EC deepening compared to prior surgery. However, cataract and macular edema have worsened, two complications that could have been avoided if proper surgical decision and choosing the right space to tackle was originally made correct. In retrospect, drainage sclerostomies alone would have been probably a sufficient primary intervention. Thank you very much.
شكرا دكتور محمد. May I now invite Dr. Fairuz Al-Azail. She will talk about microspherophecus honiopalis and
Good afternoon, everyone. Thank you for the organizing committee for this outstanding conference. Okay, I have no financial interest. My presentation is about a 25-year-old male patient who presented by bilateral diminution of vision. He denies any history of previous trauma or surgery. Generally, the patient was quite high. He had 180 centimeter and he had a highly arched palate. His span was more than the height, highlighting that he had Marfan syndrome. But thanks God, his echocardiography was normal. Ocular examination showed that the patient had miscorrected visual acuity, 260 in the right eye and 360 in the left eye, with strange refraction plus 18 with high cylinder and 16 in plus 16 in the left eye. His intraocular pressure was 42 millimeter mercury and 30 in the left eye on combination therapy. The anterior chamber was irregular. He had cup disc ratio 0.9 and 0.8 in the left eye. And this is the anterior chamber, the anterior segment photo showing a little bit shallow anterior chamber essentially. And on dilatation, he has bilateral microspherophecus. And this was the gonioscopy. The gonioscopy showed the area of 20 degrees, but with peripheral anterior synechiae, which were more in the right eye, the more advanced eye. And this is the photography showing advanced cupping in his right eye. Strangely, doing biometry for the patients showed that the axial length was 31 millimeter in the right eye and 30 in the left eye. So he has a spherical lens. He has an axial length of 31 and 30, but the refraction is hypermetropic. First, I didn't understand why this, but when I found that the EC depth is ranging between very shallow while examining on the stat lamp and the EC depth 3 millimeters on the biometry. So probably he has some sort of subluxation, so the effective lens position changes every now and then, so the refraction is a little bit bizarre. So what is the plan in such cases? Is to do laser iridotomy would solve his problem, or to do lensectomy only, or to do lensectomy and scleral fixation, or to do trabeculectomy, or to do an angle surgery. So when I reviewed the literature, I found this big paper in the Journal of Glaucoma in 2014, collecting very huge number of microspherophakic patients, about 159 eyes who had microspherophakia, and they were followed up. It was a retrospective study collecting the data over 10 years, and they found that glaucoma was diagnosed in about 51% of cases of microspherophakia, and about 60% of these patients required surgical intervention. They did trabeculectomy and lensectomy in some cases, and they attributed the glaucoma to the presence of several mechanisms, either acute pupillary block caused by forward movement of the spherical lens, or subluxation, anterior subluxation, or the presence of peripheral anterior synechiae due to unrevealed pupillary block for a long time, or chronic pupillary block due to prolonged between the iris and the trabecular meshwork, or associated developmental anomaly of the angle of the anterior chamber associated with microspherophakia. And they put a flow chart of management of these cases. So if the patient had microspherophakia and does not have glaucoma, he should be followed up annually. And if he had glaucoma, you have to discriminate what type of glaucoma. If there is a dislocated lens, so he's for lensectomy. If he had an open angle glaucoma, they give medical treatment. If he's not controlled, they go for trabeculectomy. And if he had an angle closure glaucoma, they do peripheral iridectomy. And if he was not responding, they do trabeculectomy. So the problem list in my patient that I had a patient with glaucoma and evident subluxation, and or not subluxation, but the lens is moving slightly forward and backward, and he has also poor vision. Noticing that the glaucoma is more advanced in the right eye, and he has an evidence of angle closure due to the presence of peripheral anterior synechiae. So my plan was to do lensectomy in the right eye and treating the angle at 180 degrees, and just to do lensectomy in the better eye. My concentration was, will I remove the lens and implant an IOL? Would this small bag accommodate the 13 millimeter IOL, or would I go for implanting the IOL inside the sulcus? And then when I divide the biometry, I found that leaving this patient aphakic will bring him to emmetropia. So my plan was to do a lensectomy, but keeping the posterior capsule intact, to do just compartmentalization between the anterior segment and the posterior segment, and to do GAT 180 degree GAT in the more advanced eye. And this was the lensectomy done. The capsule access was a little bit difficult because the lens was moving in all directions. Even the initial scratch, I couldn't perform it except when capturing the anterior capsule with the microraxis and then completing the capsule. My plan was to remove the whole lens matter inside the capsular bag to avoid dropping of any cortex from this in between the weak zonules to the vitreous cavity, so adequate hydrodissection and then easy lens removal. I did it under topical anesthesia because the patient had advanced cupping. Then I went to the temporal side. I performed my goniotomy, initial goniotomy, and then opening of Schlemm's canal, and notice here the presence of peripheral anterior synechiae, and then threading the 5O proline suture inside Schlemm's canal. And my plan was to treat only 180 degree because I don't know what's going on, if it would be effective or not. So I treated the superior angle. After 1 month, the patient had a visual acuity of 660 in the right eye and 624 in the left eye, and he was aphakic. The refraction was 0.75 in the right eye, 1.5 in the left eye. His intraocular pressure was 15 on combination therapy in the right eye and 12 in the left eye. And then I stopped the medication at all. The vision, the pressure was 13 in the right eye, 12 in the left eye without medications. So my take-home messages is that in microspherophake, the treatment should be tailored according to the situation, according to the type of glaucoma it is, if it is an angle closure or if it is an open angle. Lensectomy is needed in most of the cases, and never to use miotics in such cases. It will lead to inverse glaucoma. And thank you for your attention.
Thank you, Dr. Ruth, for this nice presentation. I would like to call Dr. Khalid Al-Boushi speaking about cracking the eyes.
Hello, I'm proud to be presenting in the ESG 2025. So we are talking about a very rare disease, which is eye syndrome. So maybe eliminate So we're going to talk about the pathophysiology first. What is the mechanism of disease? So this is like abnormality in the endothelium, which is change of the endothelium into epithelioid cells by metaplasia. This membrane like invades the angle, invades the iris, causing complication when it contracts, causing peripheral synesthesia and causing iris atrophy. So we have three main variants, which is the Chandler syndrome, with the affection is mainly on the cornea, causing corneal edema, and the Cogan-Rees syndrome, which is causing iris atrophy and iris nodules, and the progressive iris atrophy, which is mainly affecting the iris and causing peripheral anterior synesthesia and secondary angle closure. So digging deep into the case, this is a 20-year-old female presenting with unilateral photophobia and unilateral diminution of vision, is presenting IOP with 40 millimeter mercury, which is controlled to 20 millimeter mercury with 3 drops. On examination, slit lamp examination, we see a clear cornea, a subtle iris atrophy, and on gonioscopic examination, we see a broad peripheral synesthesia and high iris insertion into the ciliary body. On examination with the other eye, anterior segment examination was completely normal, and gonioscopy has an open angle. So digging deep into the angle, we use ultrasound microscopy for examination of the iris insertion. As we see in the left eye, in the inferior angle, at the temporal angle, we have a very high iris insertion and broad peripheral anterior synesthesia. On the other hand, on the normal eye, the right eye, we had normal iris insertion to the ciliary body and an open angle. Another note, but it's not here in the image, that we have central deep AC and no crowding of the iris angle, so we excluded peripheral anterior synesthesia. We exclude Bateau iris syndrome, and we excluded chronic angle closure or acute angle closure glaucoma. So on optic nerve examination, it shows in the left eye apparent optic nerve glaucomas changes, which is sending the shift of vessels and inferior sending of the optic nerve. In the right eye is completely normal. So the main differential with the eye syndrome is the axon field trigger syndrome, which is congenital, not acquired, which is usually bilateral and has a posterior imperial toxin rather than endothelial dystrophy, endothelial changes showing the eye cells. So the final diagnosis, this is a very early progressive iris atrophy variant of the eye syndrome, because it's unilateral and have a secondary angle closure glaucoma. Currently, it's controlled on table medical survey, no need for surgery for now, but the diagnosis is very important to look back in the literature and know what to expect. So the current management now is topical medications, but we have to counsel the patient about the possibilities and the importance of the follow-up. We showed the follow-up, the IOP every 3 months, and the follow-up with the OCT every 6 months, and we have to do a regular gonioscopy to trace the increasing peripheral anterior synechiae. Speculum microscopy should be done yearly to know if it's intersected with other variants, because eye syndrome can be present as a progressive iris atrophy, then we'll have corneal decompensation. So the surgical approaches, looking back in the literature, the most relevant comparison is a trap versus tubes, but here tubes have a higher survival of 70% versus 29% to the trap, which is makes sense because this invading membrane will cause any ostium. You have a tube that maintains its patency. Furthermore, they compared the use of mitomycin versus conventional Ahmed valve, and the use of mitomycin had a higher success. Another study in very limited cases is that have like a new intervention doing canaloplasty and really innovative step, taking a suture through the cornea and through the iris, making a heterogenic peripheral anterior synechiae, but bypassing the membrane. So the filtering is below the iris through the ostium without intersecting the membrane. Another innovation is doing combination of phacoemulsification and tube insertion, but the tube is inserted into the sulcus away from the endothelial membrane. So the surgical pills for treatment of eye syndrome try to get away from the endothelial membrane by tube placement in the sulcus or doing intersection of intersection suture to go away from the membrane. We can protect the cornea of doing desmet endothelial keratoplasty by doing a spoke-like iridotomy. This proven to increase the survival of the graft and better control of the IOP. So this is like the patient when she know the diagnosis. She was undiagnosed for 2 years. She was visiting the other doctors, and they say she has glaucoma versus she doesn't have glaucoma. When she knows the name of the diagnosis, she was relieved. So clarity, diagnosis brings clarity and brings adherence to the medical treatment when the patient know what to expect. So when you see an unilateral glaucoma, just stop and think what is the diagnosis, because unilateral glaucoma is not that common. So if you see like a subtle iris atrophy and the gonioscopy showing the peripheral anterior synechiae, you might think of eye syndrome. So early recognition
refers to the absence of the iris congenitally. It's either partially absent or completely, but even with complete absence, there's always a frill of the iris in the periphery that's occluding the angle, making the trabecula more hyperpigmented. In addition to the coexistence of an angle anomaly in these eyes as well, congenital angle anomaly that results in formation of the IOP. And usually these patients, again, develop glaucoma in older ages, and it's prudent to continue to keep an eye on anamnesia patients on a regular follow-up annually to spot the glaucoma if it develops early on. They're associated with cataracts as well as limb cell deficiencies, which make some of the glaucoma surgeries challenging, xerophakia, and again here, we opt as much as possible to adjust the angle, give it the best chance by circumferential incision. If it's performed through an aventure approach, of course, we need to be cautious about crossing a pupil, or actually the lens, in the absence of a pupil. But always remember there was a study that actually advocated prophylactic goniotomy in patients with anorexia without glaucoma at some point. So we have to just be cautious, keep an eye on the tip of the MDR until it reaches the angle and then put the lens. Sometimes it gets tricky to find which lens because it tends to be hyperpigmented. It seems with the proximity to the frill of the iris, it accumulates pigments, so it's difficult sometimes to recognize it from the peripheral iris. And then patients who are undergoing tubes, it's prudent to keep the tube as tangential as possible away from the cornea to protect it over the long term, particularly in children from decomposition, because they tend to have an endothelial problem as well, up to keeping it in touch with the lens. And even if it's lying on the lens, as you can see here, it just causes a localized opacity that is stable over the years, rather than keeping it closer to the cornea. So eventually the take-home message is that a lot of these cases need to be individualized and need to look up depending on the age, on the anterior chamber appearance. But as a rule of thumb, we'd like to as much as possible address the angle, keep the procedures at a later age if they need it. Thank you very much.
Thank you, Professor Yasmin. Thank you for your attention and for our speaker.
رغم ان انا بصي انا عاشقه في التكييف لو انا حاطه لهم الموبايل على كل الجروبات حاملهم النت يا رب ما يعرفوا صوتي انا اتفضحت يعني انا افتكرتك والله يا بنتي يلا طب المهم هو فين اصلا معايا بريك دلوقتي خلاص انا اتفضحت قولي لي يا علي صوتك عادي بحب قوي يعني ما ينفعش نوقف بس يعني مش عايزه نعمل بس اوقفه يعني طيب يقف بصي فاكره انت يوم الاورام كان لازم يقف باين اعملي عادي اللي هي قصه اتنين بس حلو والله يا اسمع انا كنت بسألك ليه لان انا بقعد اصور وفي الاخر الصور دي بتاخد